Okay. Hello, good morning, everyone. Hola, buenos días a todas, a todos.
Hi, good morning, everybody. Before we start, I would like to invite you to choose your mother tongue in this Zoom platform.
Native language is English. You can switch to English, and if your native language is Spanish, you can go back to Spanish. And the second reminder is the questions, sorry, in the chat. You can write them in the chat. Si tiene alguna pregunta, puede escribirla en el chat.
Just type in the chat any questions you may have. Let me give the floor to my colleague Rike from UNICEF so we can start. Thank you. Thank you very much.
This virtual orientation workshop, which we've organized jointly between UNICEF, PAHO, and WHO on strengthening the evidence-based development, implementation, and monitoring of investments to advance adolescent health and well-being in Latin America and the Caribbean. My name is Rike Kierkegaard. I normally work for UNICEF's Global Health Program, but I'm currently supporting our Survive and Thrive team for the region, and I am very delighted to be taking you all through the first half of this workshop. So as some of you may have seen in the concept note, we have divided the workshop into two different parts. The first hour and a half will be an orientation on two key resources for adolescent health and well-being. First of all, the updated AHA guidance, or Global Accelerated Action for the Health of Adolescents. And then secondly, the GAMA indicators, or Global Action for Measurement of Adolescent Health. And these two presentations will both be followed by Q&A afterwards. After a short break, we will then divide all of the remaining participants into breakout groups to discuss the regional implications of this guidance, and also for us to learn more from you about what kind of challenges you anticipate in implementing it, and which kind of support you will need from UNICEF and PAHO. So now, without further ado, I would like to hand over to Maike Arts, Regional Advisor for Health and Nutrition for UNICEF's Regional Office for Latin America and the Caribbean, followed by Sonja Cafe, Regional Adolescent Health Advisor at PAHO, for their opening remarks from the two organizations.
Thank you, Rike. Good morning, colleagues from PAHO and WHO, and good morning, participants from governments, civil society, and PAHO and UNICEF country offices. It's nice to see so many people interested in adolescent health and well-being. As many of you know, this year, actually in 3 weeks' time, we will commemorate the 35th anniversary of the Convention on the Rights of the Child, which includes the recognition of the right to the enjoyment of the highest attainable standard of health as one of children's rights. And it is therefore very encouraging to see that the Pact for the Future, which heads of state and government endorsed this September at the UN General Assembly, that document also includes a specific action related to children and young people. It includes a specific reference to accelerating efforts to ensure that all young people enjoy the highest attainable standard of physical and mental health. So this issue is really at the forefront of global commitments, which is very encouraging. Of course, adolescents are not just a future. They also need to be in good health today, to be active participants in society and to be able to learn and develop themselves. As you know, and as we will also hear in detail shortly, there are many reasons to be concerned about adolescent health and well-being. Just to mention a few issues that concern us: the access to quality services, adolescent pregnancy, violence, road injuries, HIV, vaccination against HPV, mental health, and malnutrition, including anemia, and as well as overweight and obesity. UNICEF is therefore more than happy to collaborate with PAHO and with WHO in this virtual workshop about two key guidance documents that complement each other very well. First of all, the second edition of the AHA guidance, the Global Accelerated Action for the Health of Adolescents, which is guidance to support country implementation. This document and documents like that are crucial for UNICEF's work in adolescent health and well-being, in support of governments and others, to make sure that we can develop evidence-informed plans in a systematic manner with the actions that are most likely to give the most results. And then the other document, the Global Action for Measurement of Adolescent Health, GAMA, which was launched in May this year, is a key complement to the guidance In UNICEF, we feel that it is very important to be able to measure action or inaction. As you know, what gets measured gets done. So this is a great workshop. We're very privileged today to have WHO and PAHO specialists here, and as well as UNICEF's global lead on adolescent health as well. So thank you all for the great teamwork, and I wish you an excellent workshop. Thank you.
Thank you so much, Micah. I guess now it's my turn. On behalf of our department director, Dr. James Fitzgerald, and the unit chief for the life course area of work at PAHO, Dr. Vega, I also welcome you to this important event. Unfortunately, neither of them can be here, but they are completely committed to making this event a success. I was asked to emphasize the importance of investing in adolescent health and well-being. As we know, in the wake of the launch of the Sustainable Development Goals in 2015, the Lancet Commission on Adolescent Health published a landmark publication, a landmark series of articles. And those articles really highlighted some key issues related to adolescent health and how important it would be to ensure that we invest in the health of adolescents to achieve the Sustainable Development Goals. One of the statements that was very important was that adolescents are historically the most underserved population in the world, because many of us, we often assume that adolescence is a very healthy period of life. And the truth is that, as Micah said very well, the truth is that adolescents face a lot of challenges, a lot of barriers. And if we do not address those, that will not only affect adolescents, but it will affect the whole population, and it will reduce our chances to achieve the Sustainable Development Goals. In 2018, the PAHO member states adopted the Plan of Action for the Health of Women, Children, and Adolescents. This was modeled and aligned with the Sustainable Development Goals and with the global strategy for child and adolescent and women's health. And so with the adoption of this plan of action that applied a life course perspective, linking the importance of investing in children, adolescents, and women, linking those populations, with this adoption, the member states in Latin America and the Caribbean committed to increase their investments, to increase their efforts. And so we do have a very concrete commitment. And again, as Micah mentioned, the commitment was echoed in the recently adopted Pact for the Future. And the Pact for the Future very much emphasizes, again, the importance of investment and strategic and evidence-informed investment in the health and well-being of adolescents and young people to accelerate progress towards the Sustainable Development Goals, taking in consideration that we only have around about 5 years to achieve those targets. And so within that context, we're hoping and expecting that the information that will be provided today and the discussions we will have will assist us in Latin America and the Caribbean to identify what it is that we can do in our region to accelerate progress. I was also asked to emphasize that you can count on PAHO support together with UNICEF and other regional partners to be with you, because our commitment from our director, Dr. Jarbas, to all of us who are working on the ground in the countries is complete. So we welcome all of you. We send special invitations to the Ministries of Health. So we want to welcome the participants from the Ministry of Health, the government focal point for adolescent health and well-being, and we wish you a very productive and very fruitful event. Thank you.
Thank you so much, Sonja, and thank you also to Maike for your opening remarks and for helping us kick off today's workshop. So we will stay with Sonja, who will provide us an overview of the current status of adolescent health in Latin America and the Caribbean. So back to you, Sonja.
Thank you. Thank you. I will share my screen for my brief presentation, and I hope that it will go seamlessly. My presentation, I hope everybody can see it.
We see it.
You see it? Okay. And is it moving?
I just see the title slide. There we go. Yes.
There we go. Okay, so my presentation is just a prelude to the meat of this meeting, where we will be elaborating on the AHA and the Gamma, but just to position where we are. And of course, in 15 minutes, we cannot address everything, but I will summarize some information that you can find in a publication, an interagency publication that we launched last year, which is a report that is titled No Time to Lose. No hay tiempo que perder. My slides are in Spanish, but just for easy presentation, I will present in English. So please, if you prefer Spanish, you can make use of the translation opportunity. And so I will touch on 7 issues very briefly. One is what are the things that we need to keep in mind? What is our current context? And then go into some of the key challenges when it comes to the health and well-being of adolescents, the impact of the pandemic, and then some recommendations. And so these things were already mentioned, not in the opening, that we do have a global commitment and a regional commitment. And I'm only highlighting here the plan of action for women's, children, and adolescent health. But of course, there are many other commitments that feed into this issue of child and adolescent health. And the pact for the future, which is again a recommendation and a reminder for us of the importance of investing, and some recommendations on where and how we should invest in the health and well-being of our adolescents. Now, what is the regional context? And it might come across as very negative. Some of these issues do not apply to all the countries, but this is overall the context in which we all live and in which our adolescents live. We have a region that is known for its diversity, and that is a strength. It's a richness, it's beautiful, but this diversity brings inequalities, because good health and opportunities are not equally distributed among the different subgroups in our region. We see that there are groups that are disproportionately affected by poverty, by poor health, and of course, by discrimination and stigma. And some of these groups are the indigenous, Afro descendants, and also the LGBT Q plus groups. Really, we see that there's a disproportion here in their access to good health and well-being. We also live in an era of political instability. We know in some countries it's to a level of violence, in others it's just changes from one political direction to the next, where that also impacts on policies. Climate change is, our region is heavily affected. I'm thinking about the Caribbean, small islands that every year see the impact of hurricanes and other climate events, but also within the United States, in Chile and other countries, we have fires. We see increasingly the impact of natural disasters that affect all of us, and of course also our adolescents. Violence. Our region is known as the most violent region in the world when it comes to homicides, when it comes to sexual violence, and of course we have the gang violence and migration. Sometimes forced migration, sometimes people looking for a better opportunity in life. And we see that this movement of people is increasing every year. Now, what about mortality and morbidity? Some of these challenges we see reflected in the mortality and morbidity. The slide you see now presents the distribution of the leading causes of death of young people 10 to 14 and 15 to 19. And I just want to draw your attention to the orange parts in the bar. You can see, for instance, that the orange bar, that is the third one, the third bar shows that our boys, 15 to 19, 41% of the mortalities in this age group are due to violence. The girls are not exempt, but it's 11%. And then there are other leading causes such as land traffic fatalities and suicides that are important causes of death for our young people. And if we go beyond death, we go to morbidity, mortality, to morbidity and disability. We have the leading causes of years lived with disability in adolescents, and it's very striking that the mental health challenges are very prominent, and it starts already in the age group 10 to 14 and becomes even more prominent in the age group 15 to 19. And it affects boys and girls. And so we see that there are slight differences between the boys and the girls, but it affects both of them. We have the mental health diseases that are on the rise and very prominent. The estimate is that more than 1 in every 7 adolescents has a mental health concern or a mental health illness. And we have depression and anxiety as the leading mental health challenges for our boys and girls. This is maybe a little bit of good news. We continue to have the second highest adolescent pregnancy rates in the world, and some projections that I prefer to not believe, say that if we continue with this trend and other regions continue with their trends, by 2030 we might have are leading with adolescent pregnancy rates. I hope we can turn that around. But so far we can see that we do have a downward trend in adolescent pregnancy. However, this downward trend is not equal in all the age groups. There are groups that continue to be disproportionately affected, such as those living in rural areas, indigenous, Afro-descendants, the poor, the less educated, are up to 4 or 5 times more affected by early and unplanned pregnancies. Now, what has been, and once again, this is a very gross summary, what has been the response to adolescents? And if we look at the period, especially since the Sustainable Development Goals, we see that there continues to be a gap in investment. There are many programs, many plans and strategies, but what the respondents often tell us is that they're not sufficiently funded to be implemented. Health services continue to be fragmented with poor quality, and we have persisting legal and policy barriers for young people to express their autonomy, to access health services as they need it, to access supportive social services as they need it, because they continue to need to have an adult with them. we have still this paradigm of deficiency, that adolescence is a difficult period and we need to focus on risk factors instead of on promoting and supporting well-being and growth. Adolescent participation in health continues to be limited, and we also see that SDG 4 says that all young people should have at least a secondary level education, and we see that in our region that goal is far from being reached. In some countries, in a few countries, yes. In most countries, no. And of course, the data from LAC and other sources indicate that when it comes to poverty, when it comes to unemployment, young people are often the most affected group. But again, it's not all negative. There are some advances. Most countries have developed plans and policies for adolescent health. In the last round of the WHO policy surveys and a PAHO survey, most countries have a plan, they have a strategy. Once again, it doesn't guarantee that there is investment, but there are plans. And several countries are implementing actions to improve the quality and the coverage of health services for young people, including the development of standards and monitoring measures, and also experimenting with different platforms such as the school and community-based services to increase access. And of course, as I mentioned, one good news is that we have managed to reduce the adolescent pregnancy rate by about 20% since the SDG targets were adopted, but we need to accelerate. We need to do better. The pandemic has contributed to a loss in some of the progress, not only in the area of adolescent health, we know in the area of maternal mortality and other areas, but we have felt the impact of the COVID-19 pandemic on some of the progress that was made in adolescent health. And we also have seen some of the risks, like many young children, adolescents, in particular girls, who did not return to school after the schools were closed for 2 to 3 years. There is an increase in poverty. We know that there has been an economic decline during the pandemic, and that continues to affect all of us. And so I'm going to close with this. In this publication that I'm hoping you will access, it's available in English and Spanish, there are some recommendations, and I think they speak really to what we are trying to do here today. We need to strengthen the formulation and the implementation of strategies and plans for adolescents that are based on evidence, that are multisectoral, and are based on equity. They are equity-based. We need to promote the policy reform that will also increase access for our young people and create a supportive environment for our young people to access services and to thrive. We need to expand the availability and use of health services that respond to the needs of our young people, meaning that it's not only treating disease, but ensuring that we have comprehensive person-centered health services that include prevention, promotion, and addressing risk factors and diseases. We need to prioritize and strengthen national systems for data collection and analysis and use, and as much as possible, disaggregated data so we can know which groups are most in need for what and how we can address that. We need to strengthen youth participation, adolescent participation, and empower young people to be partners in this process. And of course, we know as mental health is one of the most pressing issues, especially post-pandemic, we need to strengthen mental health services and integrate them into primary healthcare services, make them more accessible to our young people instead of having them separate stigmatized services. So these are some recommendations for our member states, for our stakeholders to accelerate action. And I will stop here and thank you for this opportunity.
Thank you very much, Sonja, for setting the stage for our discussion so well and for highlighting some of the specific issues and needs of adolescents in the region today. So on that note, I would now like to introduce Valentina Baltag, who is Unit Head for Adolescent and Young Adult Health at WHO. I hope I pronounced your name correctly. And she will present the second edition of the AHA guidance. Over to you, Valentina.
Thank you very much. I want just to make sure before starting that you can see my slides in the right mode.
Yes.
Thank you. So good morning, colleagues. I will present the Global Accelerated Action for the Health of Adolescents, the second edition, with a focus on what is new and how countries can use the guidance. I'm Valentina Baltag, the Unit Head of Adolescent and Young Adult Health at the Department of Maternal, Newborn, Child, Adolescent Health and Aging in WHO headquarters. Very pleased to participate and contribute to this orientation. So what is the Global Accelerated Action for the Health of Adolescents? It is a guidance that aims to assist governments in developing, implementing, reviewing, and revising national and subnational strategies and plans for adolescent health and well-being. It was first published in 2017 in support of the United Nations Secretary General Global Strategy for Women, Children, and Adolescent Health. And second edition was published last year in November. This second edition incorporates new evidence and experiences since 2017. And we acknowledge that in this webinar, some of you might be very familiar with the first edition. You probably also have strategies and plans, but some of you perhaps hear for the first time about the AHA. So we will try in this presentation in the subsequent session to accommodate the needs of both categories of participants. But I want to emphasize that AHA is more than a guidance, is more than a PDF file or a document. It is also an initiative by UN agencies to unite under a common agenda for comprehensive approach to adolescent health and well-being. And today, participants and organizers are a testimony of this common UN approach because we have our sisters agencies together in this workshop. Now, what AHA guidance does, it guides countries through a systematic approach, and I highlighted systematic approach because it is the very fabric of what AHA is about, to develop, but also review and revise and implement national strategies and plans for adolescent health and well-being. So this systematic approach is reflected in the sequence of chapters. So there is a reason why chapter number 1 is number 1 and why chapter number 3 is number 3, because chapter number 1 reflects the first step when you have to develop or review, update a national strategy and plans. You start by building the case. And this is the title of this chapter. It's the chapter that builds the case why to invest in adolescent health using demographic, human rights arguments, economic arguments, and other arguments. After you build the case and you convince your government, your partners, that it is important to develop or to review your existing plans, then you go to the next step of the systematic approach, which is described and illustrated in chapter number 2. Chapter number 2 is about understanding the status of adolescent health and well-being worldwide. It helps to understand what are the main causes of ill health in adolescents globally and regionally, and the determinants of health and well-being. So what exactly is the problem in your country? And what Sonia did just before my talk, it was a sort of a chapter 2 for the PAHO region. Then, after you know what are the key problems in your adolescent health population from the health and well-being point of view, from the mortality, morbidity, and risk factors point of view, then you have to answer the question, okay, I know what the problem is, but what are the solutions? This is the third step in the systematic approach. So chapter number 3 answers this very question. It is about identifying evidence-based interventions for adolescent health and well-being. It is a menu of what we know best today that works to prevent and mitigate problems across 6 broad areas, such as unintentional injuries, violence prevention, sexual and reproductive health, and HIV, communicable, non-communicable disease, mental health, substance use and self-harm, and also interventions in humanitarian and fragile setting. Okay, now after you've gone through step 3, you know what works. But then there is so much that can be done for the adolescent health population, and then there are different things that are needed for younger and older adolescents. There are so many problems, so many solutions to every problem. Then how to prioritize? This is your next step, step number 4. And this is described in chapter 4 of the AHA guidance, which guides you through how you navigate this complexity until you arrive at your national priorities. This chapter guides policymakers in the process of needs assessment, landscape analysis, and priority setting. At the end of this step, you should be clear about what do you and partners the government decides will be our priority for the next 5 years, let's say. Then you will have to translate this priority into actions. This is your 5th step. Translating priorities into concrete actions and implementation strategies, this is what we call programming. So chapter 5 is about how you program for the health sector action as well as other sectors. And then finally, you know what you are going to do for your priorities, you planned your actions. How do you know that you are making progress? This is your 6th step in the process of systematic updating, revising national strategies and plans. You have to monitor and evaluate your success and whether or not you are going into the right direction. And meaningful youth engagement in programming and adolescent health and well-being in humanitarian and fragile settings is a theme that is cross-cutting through every chapter. Moving on, in the remainder of the presentation, I will guide you through the contents of each chapter, but because this is an orientation, not a capacity building workshop, we will talk only about what you can find as content in the chapter and then how you can use those contents. But there will be homework for you then to really go in depth and familiarize yourself with the contents. So chapter number 1, again, it is the step number 1 in your systematic approach, is advancing the case for investment in adolescent health and well-being. It describes the latest scientific, political, and programmatic advances. It reiterates the argument why invest in adolescent health and well-being from the economic, demographic, public health, and human rights perspective. It describes what is special about adolescents, why a child health program is not enough. Why do we need to talk about adolescents in particular with their specific needs? And then it summarizes what we have learned from the pandemic and describes some of the and displacement and describes what are the opportunities. So what is new in this chapter? First, we summarize the lessons learned from the first edition. We summarized what happened in terms of scientific, political, and programmatic advances since 2017. We described the adolescent well-being framework, the investment case was updated, and lessons learned from COVID-19. What we have learned from the first edition, first of all, is that the AHA guidance was largely used by countries, and in your region, every single country has used it to develop or update national strategies and plans. Sonia made reference to the PAHO action plan for women, children, and adolescent health that was informed by the AHA guidance. But what we have learned is also that it is suitable for countries with different epidemiological profiles, that the menu of interventions in Chapter 3 is also a very useful basis to develop and to select what is context-specific and relevant for the country. We also learned that the AHA guidance and this systematic approach was applied at district level, and it works very well, even though the guidance was mostly developed with a national level planning in mind, but for large countries, district level planning and even local level planning can be guided by the AHA guidance. And then we saw that because youth participation and intersectoral collaboration was such an important feature of the systematic approach, that it indeed made a difference in how countries have approached the planning for adolescent health and well-being. So the domains of the adolescent well-being is also what is new in the second edition. We described that well-being is not only health and nutrition, but it is also about connectedness, positive values and contribution to society, safety and supportive environment, learning, competence, education, skills and employability, and agency and resilience. All these together is what we call well-being. So how you can use Chapter 1? You can make an investment case with government, with donors, with other partners. We can make a case for a comprehensive adolescent health and well-being strategy or using the well-being framework. You can develop context-specific advocacy material. You can summarize lessons learned from COVID and implication for programming. And you can reiterate what is special about adolescence. Moving on to Chapter 2, which is the status of health and well-being of the world's adolescents. And it describes the status through the mortality, morbidity burden, the risk factors, the social determinants of health, and describes selected out more in depth for selected outcomes and determinants for adolescent health and well-being listed in the left-hand side of this slide. As well, as it describes what are the key problems of adolescents in humanitarian and fragile settings. What is new? Well, first of all, we updated all the numbers related to demography and the ability adjusted life years with years of healthy life lost due to disability, because it captures more neatly morbidity, separates morbidity from mortality. And we did an overview of protective factors, not only for the health domain, but also for the other domains of well-being. How can you use Chapter 2? Well, you can use it to understand regional and global situation. It is a good reference checklist of the type of information that should be included in your analysis. So for your country, you will have to develop your national Chapter 2, so to say, that will capture the description of the needs of adolescents in your country. You can make the case for investing in research and addressing data gaps, and you can reinforce the case for comprehensive adolescent health and well-being strategy. Moving on to Chapter 3. Chapter 3, I remind you, it is understanding what works, the AHA package of evidence-based interventions. And those interventions are described across 10 broad areas listed here: positive health and development, unintentional injuries, violence, and so on and so forth. What is new in this chapter is that all those interventions were updated, because since 2017, WHO has published new guidelines, updated the recommendations, so this is now up to date. And we also included a more substantial content on positive development interventions, which in the previous edition was kind of had little space and not such strong arguments as in the second edition. Here are some examples how you will find the interventions for each of the 10 areas. Interventions are described in the ecological framework. With every table will have the same structure. You will find what are the individual level interventions. Here the example is from preventing road traffic injuries. And then you will have community level interventions, and then you'll have structural and environmental level interventions. Also in this chapter, you will find more in-depth descriptions of particular examples. Here in this example, you have the box that describes how do you integrate the HIV and STI services with contraceptive services. And such descriptive boxes are also for other areas and other important points that we want to emphasize in the guidance. How can you use the chapter 3? Is you can make an informed argument for your plans and strategies on what works. You can defend selecting some interventions because they are effective, they are in the AHA guidance. It means they have some evidence behind them. You can compare what you do with what is recommended for each problem areas. Sometimes we do things that do not have evidence base underneath. So you should ask yourself, if I do something that is currently not recommended in the AHA guidance, there might be a reason for that. Then you can plan a comprehensive, it means across all well-being domains and health areas, but also a multi-component response across all ecological levels. For example, you might do something for sexual and reproductive health that is more focused on community level interventions, but then maybe you are missing the individual level or structural interventions. So the AHA guidance chapter 3 can help you navigate those ecological level for the multi-component response. And you can inform a proposal for donor funding or research project, as well as make the case for investing in research to address knowledge gaps, because we know a lot of what works, but there are still questions to be answered. Chapter 4 is about setting national priorities. So here is where you ask yourself, okay, there is so much that can be done. There are so many problems in my countries. How can I prioritize? What is feasible, desirable, and necessary to be done in the next 5 years? So here is chapter 4 that helps you. It doesn't tell you what to do, but it helps you to navigate systematically, transparently, and explicitly through a process how you arrive at your national priorities. This process is described in 3 steps: needs assessment, landscape analysis, and setting priorities. And at the end of the chapter, there are also additional considerations. For example, the fact that priorities are not set in stone. They have to be periodically revised. What is priority today might be less of a priority tomorrow for different reasons, including because you already made some progress and there are some other areas that are underserved. What is new in this chapter? First of all, the process of national prioritization is explained through the lenses of all domains of well-being. In the first edition, it was only about prioritizing from the lenses of the health. Now it is the prioritization from the lenses of health, connectedness, agency, resilience, education, safe and supportive environments. There are illustrative examples how to do that. There is a sharper focus on gender analysis during needs assessment and landscape analysis. We describe priority setting at subnational and local levels because this was one of the lessons learned from the first edition. And there are new case studies. Well, new case studies is throughout the guidance, throughout all chapters have new case studies. So what is the practical use of chapter 4? It is a tool to inform how to conduct the 3 steps of national priority setting. It is a useful checklist for the type of data sources required. For example, in the needs assessment, we describe what type of information is needed for the needs assessment to be complete, but also we are saying, okay, where can you find the sources? And you can use the contents of the chapter to revisit your national analysis to integrate it, to integrate other domains of the well-being. And you can do the prioritization to inform district and local level planning. Chapter 5 is, after you arrive at your priorities, you should be able to answer what are the key implementation strategies, what are the actions for me now to address those priorities. It includes a revised logical framework for translating priorities into plan and programs. It describes how you plan for multi-sectoral action, and it describes implementation areas and strategies in key sectors. What is new? The logical framework is revised to integrate the well-being domains. The chapter now has a better description of the complementarity of different approaches for programming for adolescent health and well-being, because you can program in the context of a dedicated adolescent health program, but you can also do programming of adolescent health in an absence of an dedicated adolescent health program. You can program for adolescent health as plan of the health sector strategic and operational planning cycles. So those options are not mutually exclusive, ideally when they are complementary. The chapter has new evidence from the global analysis of school health programs, and it has the updated key implementation strategies in the 10 key sectors. Here is the updated logical framework. As you see now at the the logical framework, just as a reminder, is a tool that helps to make the link between what you plan to do on the bottom of the framework, key program components, all the way up to the impact. Is there a link between conducting a training course for peer educators with your end goal? So this is how you can trace the fact that your actions indeed influence different elements of the logical framework. But now at the level of outcomes, we are looking not only at the health, but also other domains of well-being. The implementation strategies in key sectors are described, and the resource banks are provided right there with the QR code for additional resources. Here you have the example for how to plan for adolescent health in housing, urban and industrial parks planning. And here are some of the key tools from our sister agencies that have a mandate to deal with housing and urban planning, like UN Habitat, for example. So practical use of the chapter 5 is to inform the logical framework of a national adolescent health and well-being strategy, to inform and revise the implementation plan, use the list of key implementation strategies for 10 sectors, to inform the planning for multi-sectoral action, and to inform an application for funding when you propose something that I want to do this because I want to achieve that. Then you have a way of showing that what you plan is linked to what you aim to achieve. And then chapter 6, monitoring, evaluation, and research, has an overview of indicators. And I will just skip this part now because our next session is about the contents of the chapter 6 and the indicators. You can see the contents of the chapter. And what is new is that we have now a set of priority indicators for measurement of adolescent health proposed by the GAMA Advisory Group, a measurement approach for adolescent health and well-being, and good practices and key principles for meaningful inclusion of adolescents in monitoring, evaluation, research, and program implementation. And the practical use of the chapter 6 is to identify and revisit data gaps in National Health Management Information System, to inform revised national indicators and targets, to develop and update M&E frameworks for your national strategies and plans, to inform monitoring framework for research proposal, as well to inform measurements when you plan a research. The guidance has case studies throughout all chapters when we show that what we recommend has been done somewhere and has been done successfully. And we have this kind of slogan of trying to summarize the AHA key messages. AHA says awesome. Those are for you to memorize it, a mnemonic to memorize the key messages from the AHA guidance. A, for adolescents are important. They are not simply all children or young adults. W, well-being means 5 domains. Effective solution exists. That's chapter 3. We know what works. S, from sectors and stewardship, both are important for successful programming. O, from ownership by adolescents and for adolescents. M, the multiplier effect throughout the life and across generations. So that's the argument of why it means every adolescent counts. There is also a manual to facilitate the process of national adolescent planning, adolescent health strategies and plans, which is a key complementary resource. For now, I will stop here and back to you, Sonia, and colleagues for questions.
Thank you very much, Valentina, for this very comprehensive overview of this second edition of the guidance. We're running a little bit behind, but we have 5, maximum 10 minutes for Q&A. I don't see any questions in the chat box, but please feel free to start writing your questions in the chat box, and I will hand over to Priyatna Banati, scientist of adolescent health and well-being research at WHO, to moderate the Q&A.
Thanks, Rika, and thanks, Valentina. A comprehensive overview of the AHA guidance, colleagues. So I hope you've had a chance to take it all in, the different chapters and the process through which we can help develop an adolescent health and well-being strategy, looking at the different components, looking at the evidence-based interventions, understanding the policy landscape, and putting the various pieces together towards a strategy that is informed, a priority setting process that is informed by these different pieces. So are there any questions? Please don't be shy. I think we have a question in the chat. Rika, I'm going to ask you for your assistance in the translation there. Thank you.
Yes. So Pablo is asking how to generate moments of exchange, reflection, and analysis of experiences of adolescent participation in these types of policy development processes.
Great, thanks. So I will definitely hand over back to Valentina for responding, but just to say that, just to point out that within the guidance itself, there are a good number of case studies that talk about the engagement of young people, meaningful engagement of young people in the policy process, when to include them, what the principles are for meaningful adolescent and youth engagement. There is a nice box in the process as well. But Valentina, I'll hand it over to you to add, please.
Thank you very much. No, very good question. The AHA guidance has many examples and tools that describe experiences of meaningful adolescent and youth participation. So there are many references that then signpost you to other resources. There is also a summary of tools how to organize meaningful adolescents and youth participation. So please look at this section. It is section 5.2.4 in the AHA guidance. So that's one source. But then there are many other platforms that features exactly, this kind of exchange of experience. To remind you that last year, a global forum for adolescents has happened, the biggest ever gathering in favor of adolescent health. It was 1.8 billion campaign, which was all about exchanging experiences on youth participation. I will ask, perhaps maybe PAHO colleagues can share a link to the 1 billion campaign. So there are many video recordings and other testimonies from young people about adolescent and youth participation. So that's one of the many platforms of exchange, and I'm sure that Sonia and colleagues can speak about the youth network in PAHO, because I know that PAHO has a network of youth serving and youth-led organization with whom the organization consults. Thank you, and back to you, Prerna.
Thanks, Valentina. That's great. And I see a few other questions now rolling in. I'm very happy that folks are not shy and asking questions, so this is really good. We may not be able to get to all of them, given that we have only a few minutes left, but what we'll do is we'll try and put some answers into the chat box itself. I'll try and do that myself, and Valentina, Regina, and myself, Sonia, and colleagues will help assist as well. But maybe we can just take one more. And this is a question regarding implementation alternatives. I hope I've translated it correctly. What other implementation alternatives do we have to provide well-being for adolescents, in addition to offering differentiated adolescent health services? And I think, again, it's a really good question. There are some really good platforms mentioned in the guidance that I think are worthwhile, and there's additional guidance as well, particularly around school health, for example. These are really also providing services for young people that fall outside of just the health sector or differentiated health sector service provision. So school health and school health programs are one that you can also look at. Valentina, can you think of any others perhaps that we could help signpost our colleagues to?
Yes, well, the AHA guidance actually is one of the intention is to be one-stop shop. When we say that, for example, gender analysis and gender focus, then we signpost to other tools that go in depth into other tools that are only about gender analysis. Or when we talk about violence prevention and how to prevent violence against children, then we signpost to other tools that are implementation tools only for this area. So in a way, AHA is a good starting point also to find the resources to go more in depth in any particular area. Then you know what are the latest implementation advocacy tools and so on for mental health, and so for each area. So that's a good starting point for going more in depth. Thanks.
Great, thanks. Super. So we'll put some responses into the chat box, into the chat, and really help to put some resources and some suggestions there. But maybe, Rika, in the interest of time, I hand back over to you for the next part of the agenda. Over to you.
And Prerna, may I make one which I forgot to say, that AHA is also a web-based tool and content. So it's not only a PDF file. We can put in chat the link to the web version of the AHA, and that offers you a more user-friendly experience to navigate through the content, because on the web version of the AHA, you can easily jump between case studies back to section 5, back to section 3. So, you know, it is how you navigate a web page. It's different from how you navigate a PDF document. Moreover, it allows us to update in a more real time the contents. For example, the new estimates for adolescent mortality and morbidity came after we published the second edition. Now we will be able to update this respective content on the web AHA. So please remember that web AHA exists as well, and it has more examples on youth participation and other aspects of planning. Thanks.
Thank you very much, Valentina and Prerna. And we can continue answering questions in written form in the chat box while continuing the next presentation. As Sonia also wrote in the chat box, that we will have another opportunity to come back to additional questions at the end of the session. We also have one more Q&A session after this last presentation, so if we have time before the break, we can return to a few questions there. But now we will move on to the last presentation before the break, and that is an orientation on the Gamma, so chapter 6, as Valentina also mentioned, and that will be done by Regina Goodholt, who is adolescent health scientist at WHO. Over to you, Regina.
Thank you very much, Rike, and it is a pleasure to be here and to have the opportunity to present on the adolescent health indicators recommended by the Gamma Advisory Group. I'll share my screen. So, Rike, is this visible in presenter mode?
It is visible, but not in presentation mode. You need to swap view. There we go.
How about this? It's
yes.
Good? Okay,
Perfect.
Great. So this is a presentation, as I said, on the adolescent health indicators recommended by the Global Action for Measurement of Adolescent Health, Gamma. So why do we actually need a set of adolescent health indicators? Well, the issue historically was that the adolescent health measurement landscape was really inconsistent and incomplete. There were many different initiatives and data collection programs and tools that used many different indicators, but these indicators were not harmonized across initiatives or across data collection tools. For example, in the SDGs, there are quite a number of indicators that relate to adolescents, but from an adolescent health perspective, they're not comprehensive, these indicators that are in the SDGs. There are indicators around adolescent health in the 100 core health indicators that WHO recommended in 2018, but again, they're not focused on adolescents. These are broad indicators across all population groups and a few here and there on adolescents, and they're not necessarily aligned with the SDGs, for example. Or yet another initiative would be Countdown to 2030, where again, we find some adolescent health indicators, but they have some specific topical coverage and they're not aligned with other initiatives necessarily. Similar thing for data collection tools, and here are a few examples. The DHS does include some questions that are relevant for adolescents, but again, from an adolescent health perspective, what's asked in the DHS is not necessarily comprehensive. There is the two school-based surveys, HBSC, that's mostly administered in Europe and North America, and the GSHS, the Global School-Based Student Health Survey. They are focused on adolescents because they're school surveys, but again, the questions asked are not aligned across the surveys or with the DHS, for example. So the landscape, as I said, was inconsistent and incomplete, which caused a lot of confusion and duplication of work and gaps in some topic areas. So the Gamma Advisory Group really was established in 2018. That was really the first step on the slide there. And the group was established by WHO and UN partners specifically to improve global adolescent health measurement. And the group set itself the goal to come up with a comprehensive set of adolescent health indicators and to then promote this set of indicators. Now, this was, as I said, back in 2018. And then the group went on in these 6 steps on the slide there to select a set of indicators that were finally published in 2024, so this year. So it was basically a 5 or even 6 year process to come up with this indicator set. It was a long process, a comprehensive process, where the second step there was to select core measurement areas first, not the indicator level yet, but measurement areas such as tobacco use, such as adolescent health programming, such as adolescent health services use. From the selection of these core measurement areas, there was a mapping of indicators done that were out there at the time, and that really led to a list of over 400 indicators measuring any aspect of these selected core measurement areas. And from these over 400 indicators, an initial indicator selection was done, and then an indicator assessment. And the indicator assessment included a 12-country feasibility study where country stakeholders assessed the indicators for feasibility. Are they feasible in their country context? Are they acceptable? Are they important? In this feasibility study, there were 2 countries represented from the PAHO region, Colombia and Guatemala. So that assessment was done. And then the last step was to include the outcomes of this assessment to finalize the indicators. And so now we have a set of 47 recommended adolescent health indicators. The whole process was driven by the Gamma Advisory Group, a group of experts, global adolescent health measurement experts. The group was selected so that all of the WHO regions, and of course PAHO as well, were represented, and different topical areas. And the process was also driven by UN partners, because Gamma is supported by a UN steering committee that represents 8 UN agencies. Along the process, there were lots of different points where inputs were collected from young people, from countries, from global and regional measurement stakeholders, and any interested expert, really, because there were also some surveys done where people could input. So that was the process. And here is the outcome. So as I said, there are now 47 Gamma recommended indicators, and they're structured into 6 domains. So here on this slide, you can see the 6 domains. The first domain is the policies, programs, and laws domain. It has 4 indicators. The indicators in bold there are core indicators that are really recommended to be collected in every country, every setting, across all adolescents. And the indicators in italic are additional indicators that countries should collect if the resources allows them. So the indicators are the existence of an adolescent health program, national standards for adolescent health service delivery, health service user fee exemptions for adolescents, and legal restrictions for adolescents for accessing health services. That's the more like high-level policy type indicators. The second domain is the systems performance and interventions domain. It also includes 4 indicators on the health services use of adolescents, on HPV vaccine coverage, on the existence of comprehensive school health services, and on schools offering HIV and sexuality education. And of course, on the slide here, you will only see the short names of the indicators. But in the actual indicator document that's in the chat, there is a link in the chat, you will get one table for each indicator where the indicator measurement details are described. So not only the short name, but there you will find the definition, the numerator, the denominator, the rationale for selecting these indicators and this indicator, and any other information around each of the indicators. The third domain is the social, cultural, economic, educational, and environmental health determinants. And in this domain, there are quite a number of core indicators and one additional indicators: adolescent population proportion, a few indicators around education, school completion, and foundational learning skills, indicators around poverty and food insecurity, an indicator on sexual and reproductive health decision-making among older female adolescents, and an indicator that combines education and employment, the NEET indicator, adolescents not in education, employment, or training. And maybe some of these indicators sound familiar to you, and that is good because actually these indicators are not new. They're based on what has been out there already. And of course, they're heavily derived also from initiatives like the SDGs because it's such an important initiative. The domain around health behaviors and risks is the one with the greatest number of indicators. It is a very broad domain. So it includes indicators around nutrition, such as overweight and obesity, thinness, the consumption of sugar-sweetened beverages, and fruit and vegetable consumption. It has an indicator on physical activity. It has 2 indicators on alcohol, heavy episodic drinking, and alcohol use. 2 indicators around tobacco use, and electronic cigarette use. It has an indicator on cannabis use. A few indicators around sexual health, first sex by age 15, pre-menarche menstruation awareness, contraceptive use at last sex of a modern method, condom use at last sex, demand for family planning satisfied with a modern method, again, an SDG indicator, skilled birth attendance. And then it has a few indicators around violence, bullying, physical violence, contact sexual violence, and sexual violence by age 18. The indicator, the domain on subjective well-being only has 2 indicators. That's because that's somewhat of a newer domain. The well-being discussion has not been led for very many years. So there are not too many established indicators. So there are only 2, someone to talk to about problems, and positive family relationships of an adolescent. And then finally, another domain with lots of indicators, health outcomes and conditions. There is adolescent all-cause mortality rate and adolescent cause-specific mortality rate. Adolescent birth rate, a well-established indicator. That's probably the one that's represented in the greatest number of other initiatives. HIV prevalence, STI incidence, injury hospitalization rate, anemia, suicide attempt, depression and anxiety symptoms, as well as care seeking for depression and anxiety. Now, it might seem like a lot, 47 indicators, but we just need to face it. Adolescent health is very broad, even broader if we try to look at well-being. But the feasibility study has shown that most countries already have data for at least half of the indicators, if not more, from previous data collection efforts. So hopefully with this information, it won't come across it quite as overwhelming. But if we want a comprehensive picture of adolescent health, we must assess all these different topical areas. There are a number of key products. As I said earlier, and as pasted in the chat, there is the main guidance document for country, regional, and global level monitoring. In this document, that's also available in Spanish, as well as in French, Chinese, Russian. Each indicator gets 1 page, but there is also a chapter on data use. How can a country use the data that they already have for action? And this is, of course, under the AHA umbrella. So using data for action, very important. Another key product is the indicator metadata toolkit. This is basically a copy of the indicator tables, but in an online format. And it is called the Life Course Indicator Toolkit because the adolescent health indicators are one component of it. There are other components on maternal health indicators. There will be components on newborn health indicators, child health indicators. There is already aging indicators and quality of care indicators. So this is basically a version of the guidance document, but in an online format, and it's also searchable. There is also a supplement in the Journal of Adolescent Health that has been published this year in May. It has 16 articles and commentaries that describe the indicator detail, including the indicator detail, the indicator selection process in great detail. 16 articles. One is specifically on the outcomes of the country feasibility study. So as we've alluded to earlier, the gamma recommended indicators are, of course, also part of AHA 2.0. As I said, one of the chapters, namely chapter 5 in the gamma document, outlines how the indicators can be used for action using the AHA approach. Chapter 6 of the AHA document does include the gamma indicators. It's the chapter where Valentina said this is the chapter on monitoring. So it outlines the gamma indicators. But I should also say that actually you've probably noticed the gamma indicators. There are some indicators that are related to policies and programs and systems, but most of them actually focus on outcomes. Chapter 6 in the AHA document is also about how to actually monitor and evaluate an adolescent health program. And the gamma indicators can be used, but they would mostly be used as outcome indicators. Countries would also need to identify indicators that help them monitor their programs as they implement them along the way. The more like process type indicators, for example, the number of, say, teachers trained in a specific topic that relates to adolescent health. These more like process indicators would still need to be defined for program monitoring. There is also an Excel-based tool that's available upon request from WHO that helps countries map in-country data that they already have available for the gamma recommended indicators. And with this tool then, once the indicators are mapped and the data have been mapped for the indicators that are available, this will help identify priorities for adolescent health in the country, as well as identify data gaps. So just to say, this tool is available upon request. And this brings me to the end of my presentation, and I'm very happy to take any questions. Back over to you, Rike. Thank you very much.
Thank you very much, Regina, for this demonstration of the complexity of adolescent health and well-being through 47 indicators. I just wanted to highlight to everyone that Sonja, Valentina, and Prerna have been busy answering questions from the previous Q&A in the chat box, so please do take a look. And multiple people asked the questions whether the presentations can be shared. Please also take a look in the chat box, as Brenda has also shared the presentations there, so you can already access them. And we now have just around 10 minutes for Q&A related to the Gamma, so please start sending your questions through the chat box if you haven't already. But we will start with a leftover question for Valentina from the first Q&A. There was a question around whether the web-based platform for monitoring the AHA standards will continue. And if so, will the Gamma indicators integrate with that, or would the Gamma have its own platform?
Thank you. I think just to make sure that all participants understand that what platform it is about. So we have a web platform that helps countries and facilities to monitor the quality healthcare services for adolescents. So quality at the facility level. And those are different types of indicators that the Gamma list of indicators. Regina just explained that this is about very few inputs, but mostly few process, but also outcome and impact indicators. So right now, another group is working on developing a consensus on quality of care indicators, and those will be reflected in the second version of this web platform for quality of care. But again, this is different from Gamma list of indicators. I hope I understood the question correctly. If no, let me know.
Yes, thank you, Valentina. Then moving on to a few questions for Regina. There were a couple of questions from Christopher. First of all, were there any small island states represented in the feasibility study? And what is the feasibility of application in small island states of this? And then another question was around, was there an assessment of the capacity for carrying out M&E in countries?
Should I go ahead, Rike?
Yes, go ahead, Regina.
Thank you. Thank you. Okay. So no, unfortunately, no small island states represented. We did make sure to have small and big countries. For example, we had India as a very big country. We had Armenia as a rather small country. We had Lesotho in Africa as a very small country. But we did not have any island states, unfortunately. Indeed, in the assessment, or rather, when we spoke about feasibility, we did talk a lot with these countries about the capacity of carrying out the measurement and monitoring and evaluation of these indicators. So yes, there was a lot of talk about that. And some of the conclusions were that going forward, we need to make sure to make it as easy as possible for countries to measure these indicators, in that they should be embedded in existing systems in countries as much as possible, which brings me to age disaggregation, I guess. Sometimes countries do actually have the data. It's just that then they're reported in age brackets that are too broad, and then that they make disappear the adolescents. So in some cases, there might be a relatively easy fixes for reporting some more adolescent health data. Going forward, we now also work with global survey programs to make sure that they incorporate some more of these indicators. For example, early next year, there is an update of the DHS, the Demographic and Health Surveys, where as Gamma, we will make recommendations on, incorporating some more of these indicators. So yes, that's what I can say in terms of capacity and, making it as feasible and as easy for countries to measure these indicators as possible going forward. But we will also move into a phase now where we will really also focus on providing country support in the context of AHA, of course, and building capacity in countries.
Thank you. Then a few quick ones. Is there any plan to have this document in Portuguese?
Unfortunately, for now, no plans, no more funding for this. These translations are very expensive.
Then we have a follow-up question around the platform for the Gamma indicators. Beatrice is asking that we indicated there was a platform, if it would be possible to share it or to have an editable version.
Sorry, I'm not sure I understand the question.
It's a question around the web-based platform for Gamma indicators that we talked a little bit about before.
Maybe the online toolkit. Does this refer to the online toolkit? I'll be happy to share a link. I'll paste it in the chat to the Gamma online toolkit. Yes, that is a reflection of the indicator details.
Thank you. There was another question from Christopher, but I see Pradna already answered, but maybe Pradna, if you want to come in, was a consideration for the effect of climate change on health in this?
Yeah, so thanks so much, Christopher. Great question. And I think, we've tried to introduce into the guidance whatever is available in terms of the evidence. We've tried to really incorporate the state-of-the-art evidence there. And I think our conclusion generally on the impacts of climate on health is that we know there are impacts, but we still don't know enough. So I just pointed you to a review that was just recently published on what's the state of the evidence on those impacts. And I hope, in fact, in our future AHA, we will have a more significant treatment of the impacts of climate on adolescent health. Back to you.
Thank you.
And
Pradna.
maybe to add to this one, there was also a lot of discussion within the Gamma advisory group on, putting in an indicator on climate change or environment, but it was really difficult to identify this one indicator that would sort of represent climate change and the impacts for adolescents. Impossible at this stage. That's why it was the idea was dropped for now. But also to say there are plans to revise the indicators at regular intervals as new evidence evolves.
Thank you very much, Regina. Let's take two questions more and then we'll end it for now. One is from Ayab that is asking, coming back to the whole conversation around the Gamma toolkit. The question is whether this is interactive and user-friendly. I'm not sure what the definition of user-friendly would be, but is it interactive and is it actionable both at the facility, the community, and the national level?
No, the toolkit is simply displays simply the indicator details. It's not interactive, actually. It just provides information on each indicator on one page.
Great, thank you. And then a last follow-up question around the small island states. There's a question around whether, for example, English-speaking Caribbean countries were invited to participate, given the importance of cultural differences among the many countries in Latin America and the Caribbean.
Is that related to the Gamma feasibility study?
I think it was a follow-up question to the first one we had around inclusion of small island states.
So just to say, in the Gamma feasibility study, we only had 2 countries from Central and South America, and they were Colombia and Guatemala.
Okay.
Yeah.
And I think Sonja also wrote a comment on that, scrolling up, that they would be, PAHO would be happy to partner with Regina to do a pilot in a small island state this next year. So I see more questions coming in. Unfortunately, we are out of time, but our presenters can keep answering questions in the chat box. We'll have to conclude the Q&A now and the first part of this workshop. Thank you again, Regina, for the attention to all the questions asked. And to all the participants at home, please do not go anywhere, as we will just be taking a short tea and bathroom break, and then come back to discuss these tutor resources further in smaller breakout rooms. So I just would like to extend a warm thanks again to all of our speakers, and I hope to see many of you again back here in, let's say, 10 minutes. So at 10:43, we will come back here.
Very well. It's a pleasure to join today's session. My name is Oscar San Roman, part of the adolescent health team within PAHO. And for the second part of today's meeting, I would like to share a few details. As you may see on screen, we will work in a total of 4 groups. As you can see on screen, basically, you can join any of the working groups. There's going to be one in English for AHA, another one in English for Gamma, a third group in Spanish for AHA, and a fourth group in Spanish for Gamma. According to the group structure, each group will focus on 2 questions, and you will have about 40 minutes to answer the questions. Basically, you have 40 minutes for the activity, and you need to focus on 2 questions, 2 sets of questions. The questions, we will share them in the chat box in a few moments, and at the same time, we will share the presentation for your reference. The first set of questions are for group number 1 and number 2, which is the English speaking group for AHA. Actually, 1 and 3, English and Spanish, AHA. The question is, what are the main challenges to anticipate in implementing the updated AHA guidance within your local context, particularly in integrating the adolescent well-being framework and concepts into your adolescent health programs? The second question, what specific areas of technical support needs do you anticipate? And finally, are there any remaining questions for the presenters or speakers? And here are the same questions in Spanish. I'll leave them on screen a few seconds, but like I stated before, we will share the questions both in English and in Spanish in the chat box for your reference. Brenda, if you could please assist me with that. Continuing. Now, Gamma groups, English and Spanish Gamma groups. The questions are basically the same. The only change is from AHA to Gamma. The question is, what are the key challenges you anticipate in implementing the Gamma within your local context, particularly in integrating the adolescent well-being framework and concepts into your adolescent health programs? Second question, what specific areas of technical support needs do you anticipate? And thirdly, are there any remaining questions for the presenters or speakers? Same questions on screen in Spanish now. Once again, there will be a facilitator from our team in each group in case you have any questions or clarifications. Now, this is the first set of questions. The second set of questions is basically focused on actionable steps or next steps. These are the two questions for the second set of questions, and that is based on today's presentations. What immediate steps can you or your organization or government take to strengthen the evidence-based development, implementation, and monitoring of investments to advance adolescent well-being in LAC, Latin America and the Caribbean? And please outline specific actions. Please try to be as specific as possible. And please let us know, as PAHO, as UNICEF, as WHO, how may we assist you further? Now the questions on screen in Spanish, same questions in Spanish. Without further ado, please join your teams and, well, I will see you. Very well. I believe everyone is back. And now I would like to grant the floor to my colleague, Joanna Lay, so she can moderate today's reporting back session. Please go ahead.
Everybody had good small group discussions. So I think we just have about 20 minutes left before the end. And so I hope it's okay. We were just going to use this time to hear back from each group very briefly. I'm not sure if each group identified a representative. And I know that maybe the discussion time was short and we had very different levels of stakeholders coming. So I think that's a benefit for us to hear these different perspectives. But I wanted to see, maybe we could just ask each group for 2 minutes, 3 minutes to summarize 3 key things. Any major challenge, speaking a little bit about insights to feasibility for either GAMA or AHA, depending on the group. Maybe 1 or 2 priority technical support requests the group discussed, and then if there's any 1 or 2 kind of immediate steps countries, especially country representatives, felt they could take forward. So I don't know if that's possible. Group 1, if we could start with, Group 1 was the Spanish speaking AHA group. Don't know if there's anybody, I know I'm putting people on the spot now. Could either be the group facilitator or maybe someone from the group just to share their insights. So I think that was maybe, whose group was that? Maybe
I think
Sonia?
it's Sanja, but it's muted.
Sorry, we have David who's going to present for the group.
Okay.
Can you see my slide?
Yes.
Yes.
Thank
Okay.
you.
Adelante, David.
Good morning, good afternoon to one and all. I would like to share details on what we discussed as a group. Now, on the first question, which are the main challenges that the updated AHA version implementation anticipates within the local context, particularly in integrating the adolescents' well-being framework concepts and concepts. Now, it's important to highlight that for our group, we had a few representatives from Costa Rica, Argentina, Bolivia, and Colombia. On this matter, we spoke about how important it is to include the differentiated component on migration for adolescents programs and plans. And I would like to highlight the Colombian context. There's a great incidence of mixed migration flows, and they all require for us to consider health from a migration perspective. And this requires for us to include the schooling, the schools, the systems, and the consequences related to missing classes, and at the same time consider adolescents' well-being and mental health. We also spoke of other challenges such as developing epidemiological indicators on adolescents' mental health. One of our colleagues from Argentina spoke and mentioned that it's a bit difficult for us to have differentiated mental health indicators that are different from psychopathological indicators or diagnosis tools, or even indicators that consider further realities aside from suicide. We also spoke about the different challenges in addressing mental health. There's a few interventions that are not that clear on mental health framework, such as which are the outcomes and the goals that we wish to accomplish, or even for evidence-based interventions on mental health as well. Another challenge to mention is the multi-sectoral approach, which requires a community approach, basically. It's about how we can identify services in a comprehensive form in such a way that the way we address health is in a comprehensive form above everything. And like I stated before, health services should be comprehensive again. Now, adolescents and their families, their communities, how can we address health and well-being principles? Education on health is definitely an important challenge to consider, especially with modern times, with social media, with digital sources. Basically, we need to understand how we can use these digital sources so as to strengthen health education. At the same time, which technical support you require? Maybe as we meet with experts and counterparts, how can we provide a multi-sectorial approach considering different routes or options? At the same time, it's about sharing evidence and socializing evidence, technical information as well. Training spaces and should not be just training spaces. They should be related to other activities such as mentorships, internships, or support in implementing diverse strategies. And also advocacy. Now, on the academia, we believe it's very important to include the academia since they do meet a crucial role throughout the implementation phases. And in order for us to assess diverse actions, we also believe we require intersectorial groups or teams, a group of resources and professionals such as from the universities and from academias. We try to provide adolescent support in a few careers, not just in nursery or in medicines. We also try to include it in social sciences. The universities, like I already mentioned, it also requires the inclusion of competencies and skills as adolescents develop. The use of technology, information, technology, and assistance in emotional well-being and mental health. For the last question, which are the main challenges? No, actually, yes, outstanding questions for presenters. how can we address interventions with boys, with men, considering a gender approach in such a way that we provide visibility for interventions from a woman's perspective, but at the same time include male health and include interventions for boys and for male masculinities, gender approaches that include masculinity. In other words, countries need to develop a plan or consider health self-care for sexual and reproductive health and rights. How can we include self-care? Over.
Gracias, David. Back to you, Joanna.
Thank you, David. Back to you, Joanna.
Thank you so much, David and Sonia. Those were really, really good insights that I think will resonate with all the other groups as well. So maybe just briefly for time's sake, I'm going to move to group 2, which was, group 2, which was the English-speaking AHA group. So maybe if you have any high-level, insights and key points you would like to share from your group discussion.
Thank you. This will be presented by Armel.
Hi, good morning, everybody. So our group was made up of Belize, St. Vincent and the Grenadines, South Sudan, Bahamas, and there was one person that joined us a little bit later that I didn't get her country. When we were talking about the anticipated challenges, we spoke about age of consent versus legal age. This seems to be an issue that we had in common. We also spoke about human resources, the challenges that we have with human resources to be able to replicate these training to ensure that everybody is able to provide adolescent-friendly healthcare services in the available opportunities. We all spoke about the existence of an adolescent health strategic plan or action plan, that if it existed or if it doesn't, we spoke about the possibilities of updating them if it's needed or developing one where there was none. In the case of South Sudan, some of the challenges he spoke about had to do with data, the availability of data, the segregation of the indicators. He pointed out that there's not an actual adolescent health program for the country, but they do have various projects that are being run by NGOs. So one of the challenges he spoke about was being able to access the data that's being collected by these projects to be used to benefit the adolescent program for his country. He mentioned a fragile political and security context that exists in South Sudan also. In regards to the question about technical support needed, one of the technical support that was identified was the development of capacity in data collection and data management in the respective countries, and also how to develop competencies in the healthcare workers. We also spoke about needs assessment and a landscape analysis assessment to be done at country level before the updating of existing strategies or the development of one in the case that there was none. So those were the big discussions, points that were discussed in regards to the AHA for our group. Do I go over Gamma also, Rike?
I think since we're running a bit behind and we did not get too much into the Gamma, perhaps you can move on to the next steps.
Sure. So maybe we'll go to group 3 briefly, which was the Spanish-speaking Gamma group. Maybe any
next steps.
Yeah, or do you want to, Amel, very, very briefly talk about the next steps
sure.
the countries can take that we discussed?
Yes. So the next steps that we had spoken about was accessing the updated AHA and disseminating it to the relevant stakeholders at our different country levels so that we can have a planning session to see what our plans were for the upcoming year and how we can start to implement these updates for countries that already have an adolescent health action plan. Our colleague from the Bahamas spoke about as next steps, developing adolescent-friendly environment, such as adolescent wellness centers, or developing capacities in persons to become adolescent wellness advocates so that they're able to reach out to the adolescents in schools and so forth. We also spoke about getting access to the Gamma report to use it as evidence to support our updating of our AHA strategic plans that exist. Did I miss anything, Rick?
Great. No, I think that was very to the point, succinct. Thanks so much, Emil.
Great. Maybe now just for the last two groups that were more focused with Gamma, maybe just one or two, highlights or takeaways from your discussion. This group 4, Gamma Español, yeah.
Sí. ¿Alguien del Gamma español que quieran? Si no, lo digo yo rápido.
Spanish focused in Gamma? Well, I will go ahead and share details. Challenges, point number 1. We focus on adolescents' active engagement, trying to always keep them engaged. Number 2, to develop certain or territorial connection, which is sometimes difficult at a national level, and at the same time to address a few indicators and its translation. Another challenge mentioned on behalf of Uruguay is precisely related to partnerships with diverse groups to standardize and to address indicators. Another challenge is the fact that in several occasions there is no specific variance, such as the ones marked in Gamma, and the database. So we do need to align efforts, and this is why this is where we do require technical support, and that is precisely how can we align this variable at a country level according to what is included in Gamma. Has outstanding questions, which is the election base for Gamma pilot plans, and the question is if all countries can participate. Secondly, are there any specific indicators on adolescents' engagement? According to what I understood, it's included within the principles, but the group wanted to know if there's any specific one that measures adolescents' engagement. Part of the requested technical support, basically it's the frequency of assessments, maybe a continuous support for assessments in such a way that we may align with adolescents' health expectations at a global level. And at the same time, standardization. Standardization because there's a few countries already working with ECLAC, and they are already working on the second updated version. But basically, it's about working with adolescents' health and relating it to the Gamma indicator. On specific measures, create a prompt implementation and prompt monitoring tool to provide a prompt response. Sometimes a few indicators take about 5 years to replicate, but sometimes, like Midi from Colombia mentioned, that for mental health, it is important for us to get to know the status at that given point in time. And even if it involves a few biases, it's still important for us to know where we are located at that given point in time. Considering a prompt, a tool that we can promptly use. And at the same time, highlight adolescents' engagement at a local, community level, and at the same time included within the consultation and within the community. That's about it. And if there's anything I missed, group number 2, please go ahead and add details. Over.
Thank you so much, Oscar, for that very good summary. If there's any other comments from group 2, feel free to put in the chat. And I'm just going to give 1 minute over to our group, which was the English-speaking Gamma. Christopher, if there's any points that we had some similar points, I think to the Spanish-speaking Gamma, if you wanted to just highlight any couple of things.
Hi, yes, thanks, Joanna. Yes, I would just reiterate very similar outcomes and concerns shared with the AHA group. I think we spoke a lot about the capacity at the local governments and data collection and management sources. who is actually doing this, and who to what capacity do they have within the local context. There can also be a local disconnect in who actually is in charge of operationalizing these kinds of frameworks, whether it be existing or proposed new ones. So if you want to integrate a AHA or integrate a Gamma where it doesn't exist, who's actually going to take control, especially when you talk about adolescents. There could be a number of different ministries in the local context. Similarly, you might have existing civil society organizations, NGOs who are already doing this work, and to what capacity are they operating at can be a concern. There can also be some legal frameworks which need to be superseded or considered when you're talking about integrating adolescent health initiatives. And then I'm thinking about any kind of cultural barriers. There should be, each of these frameworks has to be adopted at the country level because, of course, we're not homogeneous entities. So I think these are some of the major concerns that I would just add on top of AHA.
Thank you so much, Chris. And I know we're just at time now, so I'm going to pass it, I think, back to Sonia, but just to say that I think these points that were raised, hopefully the updated AHA framework does, reflect some of those needs and taking a broader public health approach and really, allowing other sectors to see their role in this as well. And also with Gamma, we know that it's new, it's a broad set of indicators, but a lot of data points exist, and that that we will be taking steps. I think Regina's here as well to work with countries and make it more practical at a country level in terms of data to action as well. So Sonia, I pass it to you for the last closing.
Thank you. I don't know if we are already at time, but can we give Regina and Valentina each one really 2 minutes to comment on what came out of the groups?
Sure, and I know Valentina has a difficulty with her background, so maybe
yes.
Prerna can come in for her.
Mm-hmm. Regina?
Sure, I'm very happy to come in. Well, I just wanted to thank everyone for their participation. It was really great to have you all so engaged, and we really look forward at the WHO and PAHO level and across UN agencies to help you with implementation of both the AHA as well as the Gamma indicators as part of the AHA process, because it is extremely important to not only collect data, but really to then bring the data together and use the data for action for adolescent health and well-being program to improve the well-being of our young people. Really looking forward to be working with you all. Thank you so much.
Thank you so much. Yes, and so maybe I just want to summarize 2 things that happened in our group, and I think were interesting for the whole group, is that Valentina responded to the question of, do countries now need to develop a new strategy based on AHA 2.0? But I think the second group responded to that, discussed that also, saying, well, this is an opportunity to review what you have and update as time permits, not only your strategies, but also your approaches, your interventions. And then the second one is that I thought was very interesting, a question from Rodolfo about self-care. And I'm very proud to say that the discussion generated interest on Valentina's part to say, hey, maybe on global level, we need to look into that in developing some guidance on how the self-care evidence applies to adolescents. So I'm glad. So every time when it comes up globally, say, hey, this started in the Americas. And so from our end, I'm very happy that so many people stayed. This is exactly how we planned it, that we knew not everybody would stay for the second part, but those who really are implementing. And so I'm very, very happy with the results, and thanks to the UNICEF colleagues. Big thanks to Regina and Valentina and Prerna. And, we will review again the results and count on PAHO to continue supporting you in the implementation of the AHA and the Gamma. Thank you. Rika, you have the last word.
Thank you very much. But I have not much to add. I think this was an absolutely fantastic session. I'm so pleased that so many of you stayed on board for the group work, because it was also really insightful for us to understand a little bit more what are some of the anticipated key challenges, and the discussion around the data with Gamma was really important for us. So we got a lot of insights out of this session as well. And we have had some of the same conversations in our group around, the key addition of the AHA really being the well-being component. So how can we now work not necessarily on doing a wholesale update, but on strengthening and sort of elaborating a little bit on these new aspects of the AHA. So yes, thank you everyone. I think it's been great, and we look forward to working with all of you to implementing this.